Welcome to the second lecture on transducer function, where we look at recording hemodynamic pressures. My name is John Boland. In this presentation, we'll have a closer look at how transducers are set up and how we balance them or zero. We'll have a look at the effects of artifact and offset error on pressure recordings. We'll have a look at the practical impact of damping artifacts and motion artifact. And we'll have a quick look at the strain gauge and throw in the Wheatstone bridge for good measure. First, we'll look at how a transducer manifold is set up in the cath lab. There are two basic ways. It's either a fixed system or a floating system. In a floating system, the transducer is simply connected to your pressurized saline bag and it's connected to the catheter and moved around at will by the cardiologist. When it's attached to a pole, the transducer itself is fixed to mid-chest level. And the manifold itself is still connected through the pressure line, but this time through a fixed transducer, but the manifold is free to move around. Either one of those ways work and can be applied depending on the circumstances. This is an example of a patient having a right and left-hand catheter with a little sheath in each groin, one for the arterial side and one for the venous side, and each has its own transducer. The sterile, single-use, pre-packed, of course. And this is an example of a floating system where the catheter that's inserted into the patient through that sheath is connected in a direct line to the transducer, and the transducer, through its little manifold system and a plunger, can inject or draw blood or saline via a port through these clear lines that are hooked up to a saline bag up the top. In a fixed transducer system, which is necessary in some situations, such as this intra-aortic balloon pump, the manifold is fixed, attached to a little vertical bar on the side of the balloon pump console. And this corner magnifies it, showing how the transducer is attached in place with a three-way tap to allow flushing from above this pressurized bag here, and then it can be flushed through the patient's system. Either system works just as well. So before transducers can be used, they need to be zeroed or balanced. That means they must be made to read zero at atmospheric pressure, and that is the baseline value. All our internal pressures are measured in relation to atmospheric pressure. We don't want to add your blood pressure to 760 millimeters mercury, so we simply calibrate or correct the transducer to read zero at atmospheric pressure. So we zero at mid-chest level, meaning we just measure the height of the patient at mid-chest. Its approximation is as good as measuring it with more refined techniques. If you zero correctly, we introduce a pressure artifact relative to the distance from mid-chest height. The difference is relative to the hydrostatic pressure difference between the two heights, such that a 2 centimeter distance from zero reference level causes a 2 millimeter error, approximately, in pressure measurement. A simple way to illustrate the effect of zeroing, meaning that the point at which you zero is where you measure. Although modern transducers are supposed to compensate for that, I think they're only compensate up to a point. So try this sometime during a cath lab term. Zero at a certain height, which the nurses do routinely at say 10, 12 centimeters above the table. There's always a convenient bowl. That's the right height that approximates mid-chest level. The alternative is to use the top of the thigh. So if you zero, say there, at the top of the thigh, then open the transducer to patient pressure and raise or lower the transducer. You will see a visible shift in the baseline pressure induced by the movement in height up and down relative to that original zero reference level. So you always zero to atmosphere. You close the manifold to the patient and expose the manifold to atmospheric pressure and then zero. Then you close to zero and you're now ready to record pressure internally. So you'll notice if you do this, Raising the transducer lowers the relative pressure, and lowering the transducer will raise the pressure. Interesting little technique to try. This is that little exercise I mentioned you should do. Here, 0, I should explain, this is just a simple trace of pressure against time with a patient on the table with an ECG. If we zero the transducer at the table height, meaning you rest it on the table well below mid-chest level, and then record the pressure of the fluid line at rest, when I did this, I obtained 81 millimeters mercury. If I then re-zero the transducer at a height around 12 centimeters, and then recorded the pressure of the fluid line, it was 73 millimeters mercury. The difference was 8. So let's have a look at some real pressure traces and the effects of various types of artifact. Again, here we have a pressure trace of an aorta on a scale of 0 to 200. Always take note of this, and your rhythm, sinus rhythm. Same patient, same circumstances, similar heart rate, similar pressures. And here you can see that this trace is sort of a subdued trace, a damped trace, the correct terminology, compared to this one, which is nice and sharp and distinct, with a sharp diastole, as opposed to being a rounded or truncated or smoothened changeover point. You can see your dichrotic notch. You can't make it out here. So these are the little clues that tell you whether it's a good pressure trace. You can make out your little markers, physiological markers like that. You can make out systole and diastole quite easily, and it's a good looking trace. This is a sad looking trace. That's because there was an air bubble in the line. It's critical to flush your pressure line so there is not even a tiny little air bubble left, although it's possible with time for the saline to form tiny little bubbles that can have a damping effect. So the pressure lines need to be flushed and tapped. You'll see the nurses furiously tapping the transducer periodically to eliminate any little air bubbles that stick to the plastic. Eliminating air bubbles, if you get damping, you can have mechanical artifacts, such as a catheter kink. If a catheter kinks, you get an interference of the normal transmission of the pressure waveform through the tubing, and that will cause something like this, even more enhanced. Position. If the tip of the catheter is touching the walls of the artery, you'll get some kind of damping artifact. You can have a leak in the system. You might have a tiny little a leak coming from a connector that hasn't been tightened up far enough. And of course, if you zero it in the wrong place, you will be recording artifactual values. And if you move the catheter up and down from that zero baseline level, you will also get artifactual values. Sometimes you can just have zero drift, and periodically you have to close the tap to the patient, open it to air, sit it at mid-chest level, and re-zero. And it's not uncommon to do that several times during a catheter. Catheter whip artifacts are movement artifacts. As the cardiologist is twirling and manipulating the catheter, you can often get superimposed waves on top of your recorded waves that generate an artifact. You'll see that in a moment. Many of the systems have built-in low-frequency filters that can magically transform a bad waveform into a good waveform and eliminate some of this low-frequency movement. We'll come across to the next slide and see that. This is called catheter whip artifact, and it can happen in pulmonary artery or the AO. This is an example from a manual, Space Labs. And you can see this is a fairly good trace, expanded, systole, diastole, presumably in the aorta. You can see the dichrotic notch. And you can see a slight little rounding in the upstroke of the aortic waveform. But you can see all these other superimposed flicks, if you like, over the natural waveform. They're movement artifacts. Movement of the catheter within the vessels causes an acceleration of fluid within the tube that is evident as these flicks, shown naturally in one of my own recordings. Again, aorta on a scale of 0 to 200 with the bottom bit cut off, sinus rhythm. You can see these are nice traces. You can make out the dichrotic notch, and then you get these little superimposed artifacts. That's movement. We learn to censor those in our minds, and it doesn't really affect our recordings. More natural examples, this time of a pulmonary artery along the top and the pulmonary wedge position on the bottom. Again, note the scale. There's a 0 to 100 in both sides, and on the bottom, again, it's the same patient. And again, we're in sinus rhythm. Take note of all these features every time you try to assess a waveform. You can see all the noise in this waveform here. At the flick of a switch, we corrected this. Similarly down here, it's a wedge, and you'd be hard put identifying exact A and V waves. Well, you can make them out. A and V waves, they're different heights and slightly different shapes, but all the noise in between would not be bold enough to give a value for every one of those, even though the computer tries to analyze A and V waves in relation to its appearance on the ECG or its relationship to the timestamp on the ECG. I would just report a mean for that. However, this magic little system had a magic little button that you pushed, and it eliminated all that catheter flick artifact to give me a nice waveform that you could analyze for A and V waves. Sadly, not all systems now have these low frequency filters. We have a Siemens system right now. They've disposed with that facility. This picture was taken from our older system, slightly older. It's not as though it's old. And it still has its low frequency filter, a valuable asset to have in certain circumstances, particularly right-heart catheters. More damping effects. If you start to squeeze the sides of the coronary artery by going in too far, it's called deep throating, you can have this sort of effect where the trace becomes truncated. That can happen from other reasons as well, but that is the most common. This can be another result where the trace simply is not transmitted because it's blunted completely by the squeezing of the vessel walls, or the opposite can happen where the pressure goes up and down above what the true aortic trace should be. You learn to recognize these over time, and it's important to make the cardiologist aware because you'd be surprised how focused they can be on the X-ray screen, and they're relying on us to be their second sets of eyes and ears and listen and look for any of these artifacts. Not necessarily artifacts, real changes due to possibly dangerous positioning of the coronary artery. Motion artifact, again, is shown here in a different way, this time in the wedge. You can see all this flickering, that's all noise. And you can see how the motion artifact results in exaggeration of just one part of the waveform. This would be the V wave, that would be the A wave, following the P wave. The A wave is exaggerated. If that's all you saw, you might be inclined to think, oh, it's a very high A wave, why is that? However, by taking a long trace, you can see that suddenly you get a more realistic value until finally you get a nice, believable trace of A and V waves. And again, you line up, the computer does it automatically, but you line up your A waves with your P wave just after and your V wave with your T waves. This would be a left atrial trace. So it's aligned very, very nicely without any time lag difference between your ECG and your actual physical recordings of mechanical pressure deflections. This is LA on a scale of 0 to 40, again in sinus rhythm. Always take note. And that would be a normal value where the mean would be somewhere around 12. That's totally acceptable within a normal range. Let's have a look at another little interesting variation. This time on breathing and the effect of breathing on airway pressure. Here we have a recording of a pulmonary artery pressure, and here we have alveolar pressure. Now, this is for a normal study, and this is for a patient undergoing positive pressure mechanical ventilation, PEEP, positive end exhalation pressure, or end expiratory pressure. Normally on inspiration, your diaphragm goes down, so your intrathoracic pressure goes down. That has a localized effect in dilating your vessels, your pulmonary vessels. So your right atrium dilates slightly, and your pulmonary capillary bed is a huge reservoir for blood. It has a huge capacitor. And what happens is all those little vessels also dilate, so the blood that's coming through from the right atrium tends to pool in the lungs just for a just temporarily, just for an instant, during inhalation, and that tends to slow for an instant delivery of that oxygenated pulmonary blood to the left atrium and to the left ventricle, so you get a drop in cardiac output. Whereas with positive airways pressure, you can see that as you breathe in also, I should have mentioned, your pulmonary pressure goes up. The converse, the opposite happens with positive airways pressure, external positive airways pressure, meaning you're intubated and oxygen is being forced into your lungs under a little higher pressure than normal. So that in normal inspiration, your intrapulmonary pressures go up, you're breathing in, then you stop and you start breathing out. Here, the opposite happens. You're breathing in because you're being forced to breathe in because pressure or oxygen is being forced into your lungs under pressure. And here the nicely marked showing the opposing effects of inhalation and exhalation with normal breathing and forced breathing. The purists used to say that we should measure pressures, intracardiac pressures, at the end of exhalation at this point. And they used to say we should ignore the top point and measure the average of the immediately preceding 2 points. That's all right if you happen to have long enough breaths where you record several beats in between. Very often, you might only have 1 or 2 or 3 beats between the bottom point and the top point. The reason for this is that at the end of exhalation is where you negate the effects of atmospheric pressure, and therefore you're recording a true physiological value uninfluenced by external factors such as atmospheric pressure. It turns out now with more recent studies that it's probably more accurate to record the mean of all of those values, systole, diastole, and mean. For years, I had so much difficulty trying to isolate those values that I simply ignored the recommendations and put down my own values. And of course, many of the senior cardiologists ignored my values, got their calipers, and measured what they thought should be the true values. You can't win. However, now we're going back to recording the mean of all the systoles, the mean of all the diastoles, and the mean of all the means. And to my mind, that has always been a more statistically meaningful and physiologically meaningful value to report. But we go with the flow. This shows the effect of airway pressure on the systemic circulation, nowhere near as dramatic, but you can still work out inhalation and exhalation. And the effect on positive pressure on mechanical ventilation, notice, is not shared by the systemic circulation, only the pulmonary circuit. Here there is no divergence. They tend to go up with exhalation as they should. Not as dramatic a change. Another example of that natural motion artifact, breathing. This time is for a case that was undergoing a fractional flow reserve, a functional assay of coronary perfusion. In simple terms, this is a trace of the aorta and a trace of the right coronary artery, inside the right coronary artery. And you can see that even within the coronary arteries, that pressure fluctuation still applies. And it can be picked up over a long trace. And it's one of the typical examples that you will see when we finally come to look at our functional studies. This is an example of fractional flow reserve, an FFR wire. Moving on to mechanics of pressure waveforms. When we look at a pressure wave, we just accept it for what it is, a measure of a pressure waveform inside an aorta. But there's more to a pressure recording than that. Pressure is shown on the left side here, again pressure against time, but on the right side we have flow against time. And consider the pressure doesn't really have direction, or more correctly, it has omnidirections. It's omnidirectional. Whereas flow, a river can flow forward or back. It's driven by gravity, of course, but flow is directional. Now, what happens with the aorta is when the ventricle contracts, the pressure travels down the aorta to the level of the bifurcation into the left and right femoral arteries. There you have a rebound, a recoil effect where pressure bounces back up the tract. So that what happens is you have a forward pressure wave and you have a backward pressure wave. And these pressures summate, but they both summate to give you the familiar waveform that we know, which is the measured waveform. The measured waveform is a summation of the forward wave and the reflected backwards wave. Whereas flow, which has direction, the same thing happens. You have forward flow with the aorta as it hits the bifurcation with the femorals, and then you have some of that flow going backwards. Not quite as much, but still real and measurable. You need special instruments, of course. This time, though, instead of summating, they tend to negate each other, so that the top waveform flow, by the time you summate, meaning you subtract this waveform, you get a different trace. So measured flow is, once again, the summation of the forward flow and the reflected flow. But in this case, the summation results in a subtraction effect. Important to be aware of those two components. Just to quickly have a look at the legend. Central aortic pressure and flow measured in a patient during cardiac catheterization. Computer-derived forward and backward pressure and flow components are shown individually. The sum results in the measured waves. I think I've explained that sufficiently, so let's move on. Let's have a look at the effect of pressure waveforms with distance. This is a graph showing different pressure measurements at the level of the subclavian artery moving distally right down to the radial artery. The further away from the aortic root you move, the more the pressure changes. And this happens as the diameter of the distal arteries lessens. The plots have been artificially realigned so that they have the same starting point. And just let's have a quick look at the legend that explains it very succinctly. Transformation of arterial pressure waveform with transmission to the periphery in a healthy 30-year-old man. The onsets of pressures are aligned for comparison. Notice as the pulse wave moves peripherally, meaning from the subclavian artery down to the radial artery, the upstroke steepens and increases in magnitude. So you see as you move further away, the upstroke of the waveform steepens and it reaches a spiky appearance distally. So that with experience, you learn to appreciate the difference between the aortic trace and, say, the radial trace. Simple enough. And the last slide in this series is waveform changes with distance. I mentioned the reflected pulses. These, again, are arterial traces with distance away from the aorta, down the length of the aorta this time. And you notice that there is a time lag in both the onset of the pressure wave. As it moves further down, it takes longer to arrive distally, and that reflected wave does the opposite. The reflected wave, of course, is closer to the femoral artery, so it makes its impact much more quickly than further up the trunk. So quickly looking at the legend again, pressure waveforms in a patient undergoing cardiac catheterization as a function of distance from the aortic valve. So these are all labeled there, and the main thing to note is that the first vertical time marks the onset of primary forward pressure wave, that one moving further away from itself, which occurs progressively later after the QRS complex with increasing distance from the aortic valve. That's just a simple mechanical effect. The further away you go, the longer it takes for the wave to travel. And the second vertical line marks the onset of the secondary pressure rise associated with the backward or the reflected pressure wave. And as I said, it just means the reflected wave takes longer to arrive up the trunk. Again, I think that should be reasonably clear, but reread all these and familiarize yourself. Make sure you understand the concepts. So how does a transducer work? This is the last little bit, only a couple of slides to go on this presentation. This is a transducer. It's simply a little magic box with a port connected to the patient via a saline tube, a diaphragm, a moving sensitive diaphragm that moves with each heartbeat, and as it moves this plunger across sideways inside a little electrical circuit. And this side of the chamber is dry and vented to air, atmospheric pressure. You can imagine that as this plunger moves back and forth with each heartbeat, these little electric filaments, or resistors, shorten and lengthen with each beat. But they're paired so that G1 and G2 shorten or lengthen together, and G3 and G4 also work together. But G1 and G3 work in opposition. What happens as you stretch a little wire, you increase the resistance across that wire. And the opposite happens. As you shorten the length of the second wire, it offers less resistance to the circuit flowing through it. This is called a strain gauge, and it forms the basis for transducers. We'll take the trouble to read this. Pressure is transmitted through port P and acts on diaphragm D, which is vented to atmospheric pressure on its opposite side. Pressure causes the diaphragm to stretch sideways, in turn stretching and therefore increasing the resistance of wires G1 and G2. So the first motion stretches these two and shortens those two, while having the opposite effect on wires G3 and G4. And the next slide will show us how these wires are electrically arranged in what's called the Wheatstone bridge circuit. We have a battery here connected to 2 points on a series of these 4 resistors arranged in parallel and in series. So that G3 and G2 form one network and G1 and G4 form a separate network. But remember, they're connected to the strain gauge so that G1 and G2 are paired. Now we have a terminal at the junction between G3 and G2 and a terminal at the junction between G1 and G4. And the way the system works, that when it's balanced, when these resistors are balanced and you introduce a voltage, there is no voltage difference across this circuit between the two terminals. So no current flows. No current flows. However, as soon as you stretch G1 and G2, you imbalance the circuit, and then the circuit registers a flow from that battery. Let's again have a look at the legend, strain gauge connection of the Wheatstone bridge. In this arrangement, if all resistances are equal, then exactly half the voltage of battery B exists at the junction of G1 and G4, and half, therefore no current will flow between the output terminals. However, when pressure is applied to the diaphragm, meaning G1 and G2 stretch, the resistances are unbalanced, so that the effect is the junction of G1 and G4 becomes negative relative to the point at G3 and G2, and current then flows across the terminal. Something you should always remember, and you should be able to reproduce. Again, sitting on the bus or waiting for the change of lights, just draw the little Wheatstone bridge circuit in your mind and imagine the previous slide with the strain gauge diagram. So remember, always zero correctly, always zero repeatedly, flush the system frequently, record pressure at mid-chest level always, be paranoid about air bubbles, and keep monitoring for damping, leaks, catheter kinks, thrombus formation. If you kink the catheter and you get a little obstruction to flow, you can form a thrombus, and that will be evident as damping. And always, it may not be your role to prepare the systems, but be aware of sterility and contamination, always. Troubleshooting, if you don't get a pressure trace, it's just experience that tells you what to do. But the problem will be that the transducer, the connections, the cable, or your entire system, and I've had problems with each and every one of those at some stage. Always it happens in the middle of a case and you have to be quick. Always check your connections first. Just pull them in and out, make sure they're not loose or wet. Check your cables that they haven't been frayed or somehow damaged. Check that the transducer has been flushed and zero correctly. You do this by doing it again. Check monitor settings. Channels and scales are correct. Sometimes a pressure wave disappears because you've inadvertently changed the scale to a pressure beyond its ability to read it. Transducer may zero and not detect pressure, meaning the transducer is at fault, or the system is at fault. And the transducer may simply fail to zero, which means the transducer is dead and you have to replace it. But you don't want to replace a perfectly good transducer, so you must go through your troubleshooting sequence. You've got to decide whether to replace it or not, and sometimes it can be quicker just to replace it and hope it works. and save all the time that needs to be done to isolate the fault. But eventually you must isolate the fault and keep the faulty transducer for checking. Now, with that, I will end this lecture. But as technologists, as technicians, we are expected to understand our instrumentation. So most, if not all of this, you must know, you must understand and recognize problems and know how to fix them. I'll end there.